Welcome to Mastering the ECG, your complete guide to understanding and interpreting electrocardiograms. From basic waveforms to advanced clinical patterns, this series will teach you everything you need to know about reading ECGs with confidence. This is a 10-part series. This is part 4. Interpreting ECGs systematically helps avoid critical mistakes. Skipping steps, especially under pressure, can lead to misdiagnosis, like myocardial infarction or complete heart blocks. By using a structured checklist, you train your eye and brain to catch both the obvious and the subtle. Let's walk through a standard 11-step approach to ECG analysis. Step 1 is confirm the patient and paper info. Is it the correct patient name, his age, and is it the right date and time? Is the machine calibrated? 10 mm per millivolt and 25 mm per second. As you can see in the square here. Step 2, heart rate. Count the number of large squares between R waves. Divide 300 by that number. If the rhythm is irregular, count the number of R waves in a 10-second strip and multiply by 6. Step 3 is rhythm. Is it regular or irregular? Is there a P wave before every QRS? Is the rhythm sinus, atrial, junctional or ventricular? Step 4. Cardiac axis. Determine the QRS axis using leads 1 and AVF. Is it normal, left deviated or right deviated? Step 5 is P-wave morphology. Check for signs of atrial enlargement or ectopic atrial activity. Look especially in leads 2 and V1. Step 6 is a PQ interval. A normal PQ interval is 0.12 to 0.20 seconds. Prolonged PQ interval is a first-degree AV block, and a shortened PQ interval is a pre-existent or ectopic origin. Step 7 is a QRS complex. The duration of a normal QRS complex is less than 0.10 seconds. Check for signs of bundle branch blocks when the QRS is more than 0.12 seconds. Abnormal voltages or pathological Q waves. Step 8 is the ST segment. Is it elevated, depressed or flat? Localize any ST changes to coronary territories. And remember, elevation more than 1 mm may suggest acute injury. Step 9 is the T wave. Is it upright or inverted? Tall, peaked T waves may suggest hyperkalemia. Inversions may reflect ischemia. Step 10 is the QT interval. Use Bayes' formula. A prolonged QT time increases risk for ventricular arrhythmias. And step 11 is your final impression. Summarize your findings in a short clinical statement. Sinus rhythm, rate 85, normal axis, borderline prolonged QTC, no ST changes. A systematic approach is your anchor in every clinical context, whether you're reviewing a routine ECG or responding to a cardiac emergency. In the next episode, we'll explore common arrhythmias and how to identify them with precision.